Thank you, Mr. Chairman. Good morning, everybody. The debates from Dr. Mahmoud Husseini asked me to be the pro for every patient with moderate or severe functional mitral regurg should undergo transcatheter edge-to-edge repair. I think this is the difficult part because we need to convince everybody have this type of functional mitral regurgitation must have mitral repair. Fortunately, the mitral clip system in Egypt since many years. Egypt is one of the countries having the mitral clip program. If we have a patient like this, 49-year-old male patient, NIHA class 3 to 4, dilated cardiomyopathy, with ejection fraction 20%, pro-BNP 12,000, pulmonary hypertension, ICD, and Euroscore 19.6%. How should this patient be treated? What is the available treatment for this patient in country like Egypt without heart-lung transplant? So the question among many others, can we estimate the prognosis in this patient? Should we improve the mitral regurgitation by surgery or an interventional procedure? Will this improve the prognosis? How effective are interventional procedures such as the edge-to-edge repair method and other devices, of course? Which patient characteristics and comorbidities will impact outcome, and which patients will benefit? How fit interventional procedures into established treatment strategies for heart failure? The mitral valve is a very complex valve. It is not round nor D-shaped. It is asymmetric valve. It's not flat. It is saddle-shaped. Its annulus is not rigid. It's dynamic. It is not passive. It's got 24 chords, and it is a very complex valve. So the science of today is the technology of tomorrow. The mitral regurgitation, functional mitral regurgitation, is a problem. And heart failure clinic mimic the mitral regurgitation, high prevalence of significant mitral regurgitation and advanced heart failure. The functional mitral regurgitation is associated with reduced exercise tolerance and increased morbidity and mortality. More than 70% of patients with heart failure present with functional mitral regurgitation and ischemic and non-ischemic. Why we have this type of functional regurgitation, ventricular annular part and arterial annular part. The mechanism of the problem, it is, I think, the functional mitral regurgitation is not leaflet problem. It is a left ventricular problem. The primary left ventricular dysfunction and the dilatation make imbalance between closing forces, reduced left ventricular contractility, left ventricular desynchrony, papillary muscle and desynchrony, reduced annular contraction. On the other hand, the tethering process, papillary muscle displacement, left ventricular dilatation and sphericity, annular dilatation, secondary chordae. This is the mechanisms of functional mitral regurgitation. What is the treatment of functional mitral regurgitation? We must go to the heart team. Valve surgeons, electrophysiologists, valve imaging, valve intervention specialists, heart failure specialists. And what available? Guideline-directed medical therapy, surgery, CABG, mitral valve repair, replacement, of course, multidisciplinary treatment, CRT, and transcatheter interventions. The functional mitral regurg, this is the therapeutic options. Look for what available. If we put all others with together, we'll find the intervention represent only 8 to 20%, including surgical mitral valve. What are the guidelines, the European Society of Cardiology guidelines for the management of secondary mitral regurgitation in patients with heart failure? Of course, heart team, the place of mitral repair using the Mitral clip system still after the non-surgical candidate or very high risk surgical candidate. And the percutaneous edge-to-edge mitral valve repair should be considered in carefully selected patients with secondary mitral regurgitation, not eligible for surgery, and not needing coronary revascularization, who are symptomatic despite optimized medical therapy and who fulfill criteria for achieving a reduction in heart failure hospitalization, class 2A level of evidence B. And in patients with heart failure, severe secondary mitral regurgitation, and the coronary artery disease who need revascularization, CABG and the mitral valve surgery should be considered. And percutaneous edge-to-edge mitral valve repair may consider to improve symptoms in carefully selected patients with secondary mitral regurgitation not eligible for surgery and not needing coronary vascularization, highly symptomatic despite optimized medical therapy, and who don't fulfill criteria for reducing heart failure revascularization. So the secondary mitral regurgitation is how to treat those patients. The transcatheter repair from the American guidelines so the functional mitral regurg, ideal setting to perform mitral valve repair. It is clear that filling the left ventricle will benefit from relief of the severe mitral regurg. Mitral valve repair can be performed with low risk surgical or percutaneous. Performing mitral repair can induce reverse for the left ventricular remodeling. So, Mr. Chairman, dear colleague, in patients with heart failure and moderate to severe secondary mitral regurgitation who remained symptomatic despite maximally tolerated guideline-directed medical therapy, transcatheter mitral leaflet approximation with mitral clip, it is safe, provided durable reduction in mitral regurgitation, reduced the rate of heart failure hospitalization, improved survival, improved quality of life, and functional capacity during 24-month follow-up. As such, the mitral clip is first therapy shown to improve the prognosis of patients with heart failure by reducing secondary mitral regurg due to left ventricular dysfunction. If we look the 5-year older, the position of transcatheter mitral repair, this for the high extreme. I think after 10-year outlook, I think the mitral repair may be totally transcatheter repair. And thank you very much.